Hello, my name is Robert Giugliano. I'm a cardiologist at the Brigham and Women's Hospital in Boston, Massachusetts. I'm here today at the European Society Cardiology meetings in Barcelona with my colleague Dr. Christian Ruff, also from the same institution. And we're here to share with the Portuguese cardiologists some new and exciting information about the largest and longest trial in atrial fibrillation with a novel oral anticoagulant known as the ENGAGE AF-TIMI 48 trial. And there was some very new data presented here today in Barcelona. And just by way of background, I want to remind our viewers that this study compared a single-dose factor Xa inhibitor given orally called edoxaban in two different dose regimens versus warfarin, and the main results were presented last November and at the American Heart meetings, written up in the New England Journal of Medicine, and showed that both dose regimens of edoxaban were at least as effective as warfarin. Both doses reduced bleeding, and they also reduced cardiovascular mortality. My colleague today, Dr. Christian Ruff, discussed some very interesting new findings with regard to dosing of edoxaban and measurement of the drug concentration levels and factor Xa levels and how that relates to clinical outcomes. And so I want to ask you, Christian, what can you say that could summarize these key findings for our audience in Portugal?
So, thank you, Bob. And it's very exciting. You know, building on the impressive results in ENGAGE, we knew, though, that one size doesn't fit all, even when we were designing the trial, and that you couldn't give the same dose to every patient, that there needed to be some flexibility, because we knew from early phase studies with edoxaban that there were clinical characteristics that were very common, impaired renal clearance, low body weight, or taking certain medications, that would both increase the edoxaban concentration and therefore the risk of bleeding. And so we knew in designing ENGAGE that we had to modify the dose or reduce the dose in selected patients to protect them from the risk of excess bleeding. And so in the ENGAGE trial, we reduced the dose by 50% in patients who met one of three criteria. They had a creatinine clearance between 30 and 50 milliliters per minute. They had a body weight 60 kilograms or below, or they were taking a medication that boosted edoxaban levels. And these common medications, P-glycoprotein inhibitors, such as verapamil, dronedarone, quinidine. And so building on the impressive results for ENGAGE, we wanted to see, did this dose modification, did this dose reduction help us manage these high-risk patients? And what we found is, even though we reduced the dose by 50%, not only did we prevent excess edoxaban exposure, excess Xa inhibition, but we had the same relative efficacy. So even though we gave a lower dose and lowered edoxaban concentration, that we didn't sacrifice any stroke reduction. But then when we looked at bleeding, we saw something surprising. Not only did we prevent excess bleeding, we actually got even less bleeding. And so by using these clinical criteria, which was over 25% of the patients at randomization, over a third of the patients throughout the course of the trial, we could identify vulnerable patients who are at high risk of both stroke and bleeding, modify or reduce their dose, and preserve efficacy, not sacrifice that stroke reduction, but have an even better bleeding profile. And so I think this gives a lot of reassurance that the doses as studied in ENGAGE with the flexible dosing, modifying the dose in selected patients based on clinical characteristics alone, really helps you navigate the tension between preventing them from strokes but avoiding excess bleeding.
Yeah. And certainly preventing bleeding is important, isn't it?
Yeah, and I think we all know instinctively that we want to avoid bleeding. And we know that, of course, fatal bleeding and life-threatening bleeding are things that have hampered utilization of warfarin. And you've presented a very provocative analysis at the ESC that looks at, where is the benefit of mortality of edoxaban? Because as you said, both doses reduced cardiovascular mortality by around 14 to 15%. The low dose actually reduced all-cause mortality. There was a trend in the higher dose. And does bleeding have to do with that benefit see with edoxaban?
Well, I think you're absolutely right. After looking into the data of the reasons why mortality were reduced, it looks like 40% or so of the reduction in mortality has to do with just less fatal bleeding, and then there's bleeding that's not fatal but very severe and can contribute to death. And then as we know in clinical practice, even if a patient survives a major bleed, they're often very reluctant to go back on an anticoagulant, or physicians are less likely to prescribe an anticoagulant again, and if you don't take an anticoagulant, you're at risk for stroke and myocardial infarction and all those ischemic events. So I agree. I think this dose reduction is a very nice feature. It preserved efficacy, it reduced bleeding even further, and I think played an important role in reducing mortality.
I think you raise an interesting point that bleeding's not just important, the fatal bleeding, but it's shocking that if you bleed, that most patients never restart therapy, and then they're exposed to several-fold risk. They're not on anything. Right. And so it seems like avoiding bleeding potentially by this flexible dosing may be really a nice fit for patients, because I think when we write prescriptions for anticoagulants, we're really worried that we're going to cause significant bleeding.
Right. Well, so that's it from here in Barcelona at the European Society of Cardiology. 2 quick updates on the Engage AF-TIMI 48 trial, and I hope you found this information interesting and useful. Thank you.